Today's guest is the Education Coordinator and CRNA for the Department of Anesthesiology at Lehigh Valley Health Network and an Assistant Professor in the Nurse Anesthesia Program for Cedar Crest College in Allentown, Pennsylvania. She received her graduate nursing degree from Our Lady of Lourdes Nurse Anesthesia Program in Camden, New Jersey, and her DNP from the University of Scranton. She is actively involved in all the enhanced recovery after surgery pathway committees at Lehigh Valley Health Network and contributes to projects of opioid-sparing anesthesia and goal-directed fluid therapy. She also has multiple publications in the American Association of Nurse Anesthesiology. Please welcome Dr. Jill Hanisak.
Well, good morning. It's so awesome to be here again. And today we have the great opportunity of speaking on ERAS, Enhanced Recovery After Surgery. And I am Angela Craig. I'm a medical science liaison with Baxter, and I am here with Jill Hanisak. So I would like to just get to know Jill and help you all get to know Jill. Jill, it's awesome to have you with us. Can you share just a little bit about your experience and what you do?
So, thank you for having me. This is great. I have been a CRNA for over 23 years, and most of them have been at Lehigh Valley Health Network in Allentown, Pennsylvania. I am the education coordinator and a CRNA for the Department of Anesthesiology and also assistant professor at Cedar Crest College for the Nurse Anesthesia Program. So I have been involved in enhanced recovery after surgery I think we started in 2015, so for many, many years, and absolutely love it. I think it's the best for our patients. Along with the enhanced recovery after surgery, a big component is goal-directed fluid therapy, and our patients have done great doing these protocols.
That's awesome. So when you say goal-directed therapy, so is this a stroke volume guided protocol? Can you kind of just walk us through what that looks like for a patient in the operating room?
So goal-directed fluid therapy uses stroke volume optimization. So we are using Baxter's NICOM, but it can be stroke volume optimization. So the best thing about that is we're able to put the stickers on, and the stickers usually encompass the chest, but we're able to put it on the back because a lot of our operations involve the abdomen. They're prepped, involves doing regional blocks and such. So if we put them on the back encircling the heart, we get that we get the information, it's accurate, and we don't have the problem of the leads getting wet, falling off, and that type of thing. We are not able to do passive leg raises because our surgeons do not like our patients being moved during surgery.
I wondered about that. I thought, I bet they don't do a lot of passive leg raises in surgery.
No. So what we do basically is if we start to see that the patient is their stroke volume may be decreasing, their cardiac index may be decreasing, these are going to be first signs that we see because our body actually reacts by vasoconstricting and maintaining that blood pressure. So we may not see blood pressure initially. So if we key into the stroke volume to the cardiac index, we may be able to prevent that blood pressure from decreasing. So at that point, we'll go ahead and do a fluid bolus challenge and see what the effect is on the stroke volume. So we'll give 250 cc's of crystalloids over 3 to 5 minutes at the most. And then it will tell us where we are on that Starling curve. It will tell us what percent the stroke volume increased with that fluid bolus. If it's greater than 10% increase, obviously the patient needed the fluid. They were fluid responsive. And then we actually will do another bolus because we want them kind of euvolemic for the surgery. So
yeah, that's great. Do you find that overall there's good compliance with that? Let me back up and say this. With this protocol, do you find that it helps really kind of make the care more streamlined from case to case, from provider to provider. Is that one of the goals as well?
Right. So basically with a protocol, it is preventing variability
Mm.
because all of this is evidence-based and enhanced recovery is evidence-based. And we may come in with our own idea of, okay, this type of case, I give 5 liters of fluid or such like that, but the patient may not need that. So this actually prevents the variability and is of more benefit for the patient.
I love that. I love
Mhm.
that. I think when we stay focused on what's best for the patient, is there like a landmark study that is one that people in all of the ORs across the country look to, or is it just a variety of studies?
So it's a variety of studies. I know a lot of them when they talk about enhanced recovery after surgery. So basically, the I call him the father of ERAS is Henrik Kellick from Denmark, and that occurred. He was a colorectal surgeon. Occurred in the 1990s, and he would go around. He was a surgeon. Go around with his residents and say, "Why is this patient still in bed?" And usually the reason came back to they had a delay in bowel function. So then he looked at basically what was the problem with this delay in bowel function. So, no surprise, he basically found they were getting opioids, and opioids are stopping the gut from
Mhm.
that's peristalsis and going on. But a big one also was the IV fluid management.
Mm.
So, if these patients get too much fluid, which honestly we probably were doing for years because we weren't basing it on any evidence that was out there, then the bowel gets edematous and it's not going to function at that point either. Surgical approach is part of it, but I think anymore we're laparoscopic or robotic, so that's kind of good. And the patients were laying around in bed; they weren't getting up and moving either. So those were the things. So I actually still Henrik Kellig just wrote another article about kind of where we're going with ERAS. But there's a lot of articles out there with people talking about their protocols, but also goal directed fluid therapy is mentioned in every single one.
We're really looking at a variety of things that
Mhm.
they're trying to encompass that's best for the patient. Is that something that's pretty standard? So even before they have surgery, are there things we're doing to
Mhm.
try to enhance their recovery?
So anymore, initially it was kind of just looking at pre-op and education of the patient is key. Um, Also, carbohydrate drinks. So they'll have a carbohydrate drink the morning of surgery. Not having these patients fast all night. They can have clear liquids up until surgery. What we found is that that the carbohydrate drink was actually decreasing insulin resistance that occurs normally with any surgical procedure. So it was definitely a benefit to the patient. Some of the other things is the multimodal medications that they would get. But now what we're looking at too is they're looking at prehabbing. Can we get people from stopping to smoke? Can we get them better in shape for the surgery that's coming up? So a lot more is going into getting these patients ready for the surgery. And we want them to return to baseline or even above baseline after the surgery.
That's awesome. So it's really looking at what is best for these patients. And my good friend, had colorectal surgery, and it was interesting. She had her little notebook. She had to go to colorectal school. They sent her to a class before the surgery and gave her all of the information, and she did amazing
Yeah,
with her procedure. And I do think there is proof in the pudding, right?
definitely.
It makes a difference. Now, would you say that getting everyone on the same page is easy?
No. So I
Tell us
think,
about that journey.
yeah, so I think a big part of it is, and one thing that was frustrating to me is obviously I concentrate a lot on the intra period. Yeah, we want the acetaminophen and the medications pre op, but intra-op is key. And when you read the studies, they basically said they didn't give what they were doing intra-op. They basically said they told anesthesia providers to opioid spare. Well, that can mean a lot of different things with a variety of people. So we actually, in our protocols, will give suggestions of what to do. And what we find is using propofol infusions, so not using gas. People have less post-op nausea and vomiting. They do better with that. And then other multimodals hitting different pain pathways and also helping with the modulation of pain. We oftentimes, especially, I think we always talk about colorectal surgery, but there's other surgeries we can do. But any type of fascial plane block or some type of block for these patients also does well with them. And many times you can get through these surgeries without actually using any opioids. And then if the patient has pain, they're opioid naive and they take a very small amount of opioid to get some pain relief afterwards.
Wow.
So that's key. Now, people don't like to be told kind of what to do, but
Right.
we have the data to be able to prove that we have good results with these. So we encourage our people to follow that. Um, One of the things with the goal-directed fluid therapy is I had a group of DNP students who did their project on coming up with a reminder that this was an ERAS case and you need to use the NICOM. So that would pop up as soon as they logged into the computer when they came into the room. And we definitely saw an increase in the utilization of the NICOM. So,
And so, can you just share a little bit about what your protocol looks like? What are the patients who you really kind of focus on? Is it mainly the colorectal, or are you branching out into multiple different surgical areas?
anywhere we can. So basically, yeah, colorectal is where we started. After that, we moved to laparoscopic donor nephrectomies. Now we're doing robotic donor nephrectomies. So these are patients who are, altruistic patients who are coming in and donating a kidney to someone else. It's great. These patients, it always amazed me, were in so much pain
Yes, I've heard that.
normally, and yet we were doing tap blocks. So we were doing tap blocks, we were giving opioids, but they were in a lot of pain. So we looked at then revamping, still doing tap blocks, but putting in the multimodal medications pre-op, putting in basically an opioid sparing, very sparing, if not opioid free intra-op. And a lot of patients didn't really take opioids afterwards. We did goal-directed fluid therapy, and our results were really good. So we looked at pre-ERAS and post-ERAS. We looked at what their creatinines, making sure that their creatinines didn't bump up from ERAS, and they were very similar. So there was no detriment to them. We used goal-directed fluid therapy, and we decreased our intra crystalloids by 2 liters.
Wow.
So they didn't need all that fluid. And the surgeons actually were a little bit, do we believe that? But yet they did, because they could see the vessels and see that they were fine, that they were not hypovolemic or overhydrated. So it was good. We looked then at our length of stay, and we were able to decrease that by about 1 to 1.5 days. And the biggest thing that I think is just wonderful, and I think it's why our patients were able to really move around a lot, not have post-op nausea and vomiting, is that their overall morphine milligram equivalents, so their opioid dosages, decreased by 72%.
Wow.
So it's just phenomenal to me. And even their PACU decreased by 83%. So they were not coming out in pain, and their opioids actually decreased. And a lot of patients wouldn't take any opioids at all and just continued with the acetaminophen and the pregabalin post-op.
Wow.
So it was great to see. And they weren't having pain like they had been prior. So
Yeah, it's hard to believe, isn't it?
it
Less
really is,
opioids, but yet less pain. So that's
because you're
amazing.
hitting pain
Yeah.
pathways in different spots and
Yeah.
before the surgical stimulus occurs. So it's key.
Right.
Yeah.
That's amazing.
So
So do you normally try to optimize the patient by looking at in advance, looking at where they're at baseline stroke volume to know where they kind of live prior to surgery, and then you monitor that.
Right.
Okay.
So it's put on prior to induction, even
Awesome.
before we put them to sleep, that we have it on and have what their values are.
That's amazing. So what I've always heard and what I've always read about, that typically stroke volume decreases before the blood pressure decreases.
Mm-hmm.
So then you get an opportunity to intervene before you have hypotension. Do you find that that's the case for you guys?
Definitely. Yeah. And you have to keep looking at it and be aware of what's going on. And you have to look too at what's going on with the surgery, but you will see definitely those decreasing beforehand. And we have the total peripheral resistance index that you're going to see increasing
Mhm.
as they're vasoconstricting to maintain that blood pressure. So you really do see all of that.
Yeah. And then I think it's nice too to see that cardiac index, cardiac output too, to see how that plays into what's going on with this patient. So that's really exciting. Well, wow. I hope that everybody is getting a little jazzed about ERAS. This is definitely something that's important, and there's a lot of literature out there. And if you have a hospital that doesn't have protocols in place, this is an opportunity for you to ramp up your protocols. Now, as far as Jill, if somebody's listening to this and they say, hey, we want to find out who this Jill person is there a way that they could potentially reach you? Or can you tell us how we might be able to reach you?
Sure. You can reach me by email. And you can do, so it's Jill, Jill Hanisak, Hanisak at lvhn.org.
Awesome. Awesome. And is there anything, any final words or in words of encouragement to maybe someone who's out there that's in a position similar to yours that is just struggling with this implementation?
Keep at it. It is so, I mean, I'm an old dog here. And I've been looking at the evidence that's out there. And if you keep up on things and implement it, it's just so rewarding. I mean, we gave everyone opioids all the time.
Absolutely.
And we didn't think anything about
Right.
fluid. We just kept giving a lot of fluid. So we can change. Change is hard. And just be persistent with it. Education is key for the staff. And reminders. I think reminders definitely help to pop up to let people know and let people know we're watching. We get better results. And then when you get results, take the results back to the staff. They need to see that this is actually working.
Yeah. And you said you're an old dog, so old dogs can learn new tricks.
They definitely can.
Well, this has been great. Thank you so much, Jill, for all your time and your expertise, and for just overall really taking the time to roll out protocols that can really enhance patient care. So thank you for all you do, and thank you for this time together.
Thank you.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.